Hello everyone and welcome back to our continuation of Endo 101, the truth, the myth and the answers, part of Wear Yellow SG EndoMarch 2025. My name is Namira and I'm honored to be here again as we address the remaining questions from our previous session. During our last talk, we received an overwhelming number of insightful and thought-provoking questions. Your curiosity, your courage and your willingness to seek knowledge truly moved us. However, due to time constraints, we couldn't get to every question during the live session. We know how important it is to have clarity, especially when navigating a condition like endometriosis. Every question represents someone searching for understanding, reassurance, or a path forward. That is why we are here today to ensure that learning, advocacy, and access to information remain continuous and available to everyone who needs it. Joining us once again is the incredible Dr. Mali, consultant at Dr. Mali Clinic for Women and Advanced Pelvic Surgery. She has graciously made time for us today to provide expert insights and guidance on the remaining 20 over questions we received from you. Dr. Mali, thank you so much for being here again. Let's dive right in our first question, and that is, many doctors claim to specialize in endometriosis, but how can we truly determine if they have the expertise? Are there any guidelines or criteria for identifying a qualified endometriosis specialist, Mali?
Okay, so very good question. Right now, worldwide, there's no guideline on identifying what is qualified endometriosis specialist. But if you see a doctor, so I think in our previous talk, we went through some of the common myths and mistakes that people were given at the time of consultation. So if that kind of mistaken information was given to you, you should be very careful during the consultation. And actually, there is a few. There are actually some guidance. For example, for endometriosis specialists, in one of the website or in one of the endofound.org, there's a certain criteria. So for example, for endo specialists, we do need to perform a certain number of cases, especially for stage 4 endometriosis. You have to fulfill that criteria in order to gain the experience of dealing with endometriosis. So when it comes to surgery, what we don't want to see is for someone who's not trained to do endo, go in, find out the disease cannot be removed, and leave the endometriosis disease inside, do an incomplete surgery. So a few criteria, for example, at the time of consultation, you need to see how this doctor is diagnosing endometriosis. So commonly, we do use ultrasound scan, endometriosis mapping scan to diagnose endometriosis. And as we discussed before, a complete endometriosis mapping scan should not only focus on uterus ovary. So if you find, okay, the ultrasound scan assessment is only focusing on uterus ovaries, then it is the incomplete mapping scan report. And quite commonly, most of the severe disease will be missed if the scan only focuses on uterus ovary. So a complete mapping scan tells you the location of endometriosis, not only in the reproductive organ, but also including the urinary system, bladder, ureter, kidney, bowels, or the ligament behind. So that's what a complete endometriosis scan should include. So that is one way of assessing whether this doctor is familiar with diagnosing endometriosis. And when it comes to consultation, again, so that's the experience that you have, especially if you can pick up some of the red flag signs or wrong information that's given to you, then it might be a good idea to double check the facts and then, if necessary, go to seek second opinion. It is also good to ask their experience. So when it comes to surgery, if certain types of patients do need a surgery, it is also good to check with the surgical approach that the doctor used, like how many cases that he has performed, And what if there's endometriosis diagnosed intraoperatively, and whether he thinks that the doctor is confident in removing all the endometriosis. So this is some of the things that you can use to decide whether this doctor have enough experiences in dealing with endometriosis.
Thank you for the detailed explanation, Dr. Mali. We'll move on to question number 2. What causes endometriosis? I've heard it may be hereditary and could develop during fetal development. Is this true? As a mother watching my daughter suffer in pain, I can't help but feel a deep sense of guilt, wondering if I pass this condition on to her. The thought alone is heartbreaking.
Oh, yeah. So please don't feel guilty about this. Although endometriosis, there are certain component of genetic hereditary, doesn't mean that this gene would actually pass on for sure from mother to daughter. So there's multiple genes that are responsible for endometriosis, and the reason why it occurs actually because, yes, you're right. So endometriosis actually developed during fetal development. When there is a cell differentiation, certain types of cell started to develop into endometrial cells at different part of the body organ. But when the girls, before the girls having period, these cells tends to be quiet. Then after the girls started to have menses, that's when the ovary started to produce female hormones. And this female hormones will stimulate the silent endometrial cells to start become active, and there will be flare-up. Then multiple flare-up will cause the endometriosis to grow, to progress, and then gradually that's when it starts to cause pain. But it's not like very obvious link of genetics. So although there's multiple genes that are responsible for endometriosis, but that does not explain the full picture of endometriosis development. So please don't feel guilty about it. And we know that endometriosis, unfortunately, is just so common. And the important things actually is for early recognition and early intervention. And if we can diagnose early and intervene early, there's more than enough options to prevent the disease from progressing into a severe stage. So that's what we should focus on at the moment.
Moving on to question 3. Okay, so for question 3, the next few questions, in fact, question number 3, 4, and 5 are all pertaining to Dienogest. Just to simplify things, question 3 addresses its general side effects. Question 4 focuses on its impact on fertility. Question 5 concerns its effects after menopause. So let's zero into question 3 first. Is generic Dienogest as safe as branded versions? Are all hormonal treatments safe long-term? I heard that they carry risks like bone loss, metabolism changes, mental health effects, weight gain, and GI issues. Is this true? How can patients minimize risk? Are there safer non-hormonal alternatives to endometriosis management?
Okay, thank you for this question. I think the generic Dienogest recently came to Singapore for the past, I think, 3 to 4 years' time. Whenever we assess the safety of the medication, usually because Dienogest or all these hormonal treatment, we do emphasize on long-term treatment. It's not like, okay, we need to take for 1 or 2 years, then after that stop. So that's why we do need a lot of long-term safety data in order for us to decide whether this medicine is safe to take long run. So the branded one, yes, we trust it because they have spent a lot of time and money doing long-term safety research. I think the branded one has been on the market for more than 10 years, and they do spend a lot of efforts studying whether it's safe to take this medication for long term. For example, initially when this medicine was on the market, they actually put a label saying that this medication is labeled to use for up to 2 years time. And why is that? Because that might be a long-term concern on bone loss. So in that few years time, there are actually various studies who studied the long-term effects on the bone density. So they do regular bone mineral density studies for those patients who are on long-term Dienogest, or even more than 2 years, more than 5 years time. And during the subsequent many years of study, we have found that although there is mild reduction in the bone density, but most of the time it just stay in the osteopenia range, means that it's low, but it's not abnormally low. So it doesn't go down to osteoporosis. And this bone loss is recoverable. And if we add on calcium tablets, then the risk of the impacts on the bone loss actually is minimal. So that's why we come to the conclusion, yes, long-term usage of Dienogest, there are some bone density loss, but doesn't go to osteoporosis and doesn't translate to clinical fracture. So with this medicine on the market for very long period of time, there is more and more long-term safety studies. So now if you actually have the medication label, you can go and read, you get a study. So for the branded one, they actually have removed the limitation of duration of usage. So previously when it comes out, it's 2 years. Now they have removed it completely. So that's when it comes to generic. So whenever because I know there's many different brands of Dienogest available on the market. So it's always important to look at the medicine label, go read the information about it, because from what I know of, then some of the brands, they still have certain limitation of duration of usage inside. So if you read that, if that message is available on that medication, I think it might be safer to change someone who has more established long-term safety data. So they do carry certain risks. So all these risks, yes, in the branded one, because we have more research on this area. So I answered about bone loss. Metabolism changes, it applies to all progesterone treatment. So Dienogest is a kind of progesterone, right? So progesterone is similar as pregnancy hormones. So this does carry a certain metabolism changes, including the cholesterol, including the sugar, etc. So that's why for those, before we initiate any long-term hormonal treatment, it's always to have detailed examination and history taking, make sure that this patient do not have any contraindication in starting certain types of hormonal tablets, because it will be a long-term. For example, if this girl is having a very poorly controlled diabetes, and he's in a phase where he's still trying to adjust the dose of the medication to control the diabetes, then it might not be a good idea to add on progesterone treatment, because it will affect how they adjust the diabetes medicines. But once the sugar control is better, once they stabilize on the dosage and the dosage of the diabetes medicine, and then we can slowly introduce the progesterone treatment for this group of girls. Mental health effects, yes. So for all progesterone, again, it applies for all progesterone medications. But what we do realize is that most of the mental, like mood swing, etc., they occur in the first few months when we just initiate the treatment. So from the data wise, we know that 30% of the women, when are on progesterone treatment, they will have mood swing. But when it comes to severe mood swing, for example, depression, etc., it's less than 1%. So it's important to observe in this initial phase how the mood changes. If the mood swing is too severe, or even develop depression or suicidal thoughts, then we know that this medicine is not suitable. Then we have to change to other medications. But there's still about 70–80% of the time, the patient are pretty happy with it, because that does help with pain. And then it's okay to continue taking this medication. The other way of dealing with mood swing, usually what I tell patients is that, because everybody's metabolism of medication is different. So the peak of action of each individual medicine is different. So for example, if you have a lot of mood swing, if you take the medicine in the morning, maybe you can try to adjust the timing of the medication to see which timing suits you better. So by adjusting the timing of the medicine, the peak of action will be a bit different. So it may occur at the time you're sleeping. So they might help with mood swing initially. But of course, warning signs, if for those who develops like very, very depressed thought or suicidal thought, then we need to stop this medication. Weight gain, again, is the same because for all hormonal treatment, especially for progesterone, they do cause water retention. So that is one of the very common reasons for weight gain. But this weight gain, usually it is recoverable. So once the body is getting used to this medicine, the weight tends to be normalized. Yeah, so yeah, I think, are there any safer non-hormonal alternatives for endometriosis management? When we talks about medical treatment for endometriosis, because we need to know how endometriosis occur, right? So there's endometrial cells, and it is the hormone that is produced by the ovary that will stimulate the endometriosis to grow, to cause bleeding, then bleeding will cause fibrosis, etc. So when we understand the physiology of why endometriosis occur, then we will be able to understand why we use hormonal to treat endometriosis, because for all hormonal treatment for endometriosis, the aim actually is basically to reduce the level of estrogen in the body. So that's why we use progesterone, we use pregnancy hormone, because these can help to reduce the estrogen level in the body. Is there any other non-hormonal alternatives to reduce estrogen? I doubt it. So far, there hasn't been any proven ways of non-hormonal alternatives for medical treatment for endometriosis.
All right, thank you so much, Dr. Mali. Question 4 and question 5, the next one is actually pertaining to the same issues. Question number 4 is pertaining to fertility and Dienogest, so just simplify it. Whereas question number 5 is about menopause and Dienogest. So maybe you can simplify the answer.
Yeah, so how does egg count correlates with fertility chances? Yeah, so for us to get pregnant, there's a few steps, right? So we need to have healthy and enough number of eggs to begin with. Then for natural conception, we also rely on the fallopian tubes, so which is a passage for the eggs and sperms to meet. And also we need to have a healthy uterus to host this pregnancy. So egg count does affect fertility chances, because if the egg count or egg reserve is low, then, or if the quality of the eggs is not good, then there will be less chance to fertilize, to have healthy embryos. Thus, it does reduce the fertility chances. Will Dienogest medicine impact egg count? No, because Dienogest, the way it works is to reduce estrogen. So by reducing estrogen, it will reduce the progression of endometriosis. So in a way, it does help to protect fertility. Egg count itself is more impacted by endometriosis. So pregnancy hormone itself, it doesn't affect the egg reserve. Yeah. For those with long-term Dienogest, what can we expect after reaching menopausal age? So again, when we reach menopause, the ovary will stop producing estrogen. So that is the time where we can stop Dienogest already. So usually after menopausal, hormonal treatment is not needed because there will be no estrogen produced. But then comes the question of whether endometriosis can stop progressing after menopause. The answer is, for certain types of endometriosis, it may still continue to cause symptoms of pain and may slowly progress, especially for deep infiltrating endometriosis. And again, these are the types who also would not respond to Dienogest treatment in the first place. So yes, after menopausal, we can stop Dienogest, but we still need to monitor the progression of endometriosis for certain types, especially for the deep infiltrating endometriosis.
Okay, moving on to the next question, question 6. Why do some doctors still believe outdated myths like pregnancy treats endometriosis or hysterectomy cures it? And how can we push for better education in the medical field?
Thank you so much for this question. I think, unfortunately, as what you said, many people are still a little bit outdated in the management of endometriosis. So that's why we're actually doing awareness campaign for many, many years. So actually, awareness campaign does not only aims to improve awareness in public, but also we are doing various activities to teaching sessions to to family physician doctors, to specialists, to let them know, okay, what is the proper ways of diagnosing and treatment of endometriosis. It takes time, but I do see that within the past 10 years, people also begins to change the way they treat endometriosis already. But again, it takes some time for things to, I mean, worldwide is the same problems. All the doctors do need to be educated, not only from primary care physician, but also from specialists in gynae and also specialists in other areas as well, so that we can have a better understanding of this disease. So education takes time. Yeah. So that's why I think I always believe in self-education, even from patients. It's always important to know, because as patient, you know yourself the best. So if you see a doctor who doesn't seem to understand so much about endometriosis, maybe it's better to seek second opinion and get the answer for the pain. So how can we push for better education in the medical field? It starts from medical school. So when I was still in the public institution, because previously there's very little emphasis on chronic pain and endometriosis, but for the past 6 to 7 years, we have incorporated this topic in the medical school educations as well, so that the medical students would have a better understanding or have this conception of this disease. And then when it comes to specialist training, I believe with everybody's effort, when we know more about this condition, we will educate our juniors on how to identify and how to diagnose and how to do a proper treatment for endometriosis. Yes. It's still a long way to go, but we do see some changes starting to happen.
Recording in progress. So patience is the key, and keep advocating, everyone. Yeah. Okay, moving on to the next question. What is an effective option to treat bowel endometriosis?
Yeah, so bowel endometriosis in the category of deep infiltrating endometriosis. So when it comes to bowel endometriosis, again, it is important to know a few factors, including what is the size of the endometriosis and what is the depth of invasion of bowel endometriosis. Depth invasion means, because for bowel endometriosis, usually they invade it from outside in. So they will start to touch the outside layer of the bowels first, then gradually they will invade into the muscle layer of the bowel and then started to cause problems. So depends on the size, symptoms, and depends on the depth of invasion, the treatment option might be different. So for example, so again, it comes to the importance of doing endometriosis mapping scan, because the mapping scan actually can give us all the information that we need to decide what is the best way to treat bowel endometriosis. So in the mapping scan, we will be able to tell, okay, what is the size, what is the depth of invasion, and what is the distance of this bowel endometriosis from this nodule to endoverge, means that from the anus, how high it is. And also it will be able to tell us what is the relationship of this bowel endometriosis to ureter. So if you can have Google a picture of online photos, you actually can realize that actually in the pelvic area, the bowel can be quite close to ureter, especially if you have bowel endometriosis there. Then the common site of bowel endometriosis usually would affect the uterosacral ligament, which is the ligament behind the womb. And right next to the ligament will be the ureter. So it is important to see how far this bowel endo is away from ureter, because if it starts invading the ureter, then that will be another big issue of affecting kidney also. So all this information will be able to get from the endometriosis mapping scan for us to decide, okay, whether we can still have the time window of trying something conservative like medication, although it doesn't help with the disease. For example, if the bowel endo is still very, very superficial, haven't invade into the muscle and very far away from the ureter, and the pain is well controlled. So in these kind of cases, we do still have some time window to close monitoring and try with hormonal medications possibly. If the pain is well controlled, the disease is stable, then we can continue monitoring. But if we find, okay, this bowel endo is still progressing and started to affect slightly more or invade deeper into the bowel, or even with hormonal medications, still having a lot of pain, or it started to spread laterally, affecting or going closer and closer to the ureter. This is the kind of cases that we do need to do surgery. So surgery also, there's surgery including shaving of bowel endo for slightly superficial disease, or this resection is usually applies for nodules that is less than 2 centimeter. This means that we only cut cuffing the anterior wall of the rectum, just a small part of the bowel being removed, rather than whole segment of the bowel removed. But if the nodule is more than 2 centimeter, usually we do need to do a proper bowel resection. The whole segment of bowels have to be removed and then we connect it back together. So the effective option would also depend on how severe the bowel endometriosis are. But the aim actually is for, if we need to go for surgery, is the aim actually need to be clearance of the bowel endo, or else there's high chance that if there's anything left in the bowels, there's high chance that symptoms would still comes back.
Right, but I feel also it's important for people out there to understand that the approach that you are saying is based on your expertise, and not everyone specialize in doing such map scanning. So the first and foremost for patients, I believe, is to please approach the correct specialist so that you are able to get a proper consultation with all this proper map scanning and whatnot. All right. Okay. So let's move on to the next question. Question number 8. Okay. So this is a term I'm not very good in saying it out. Is Medroxyprogesterone a good treatment for endo? What efficacy and what are the side effects, Dr. Mali?
Okay, so very good question actually. I think at least 1 year ago, actually we're still using a lot of this called DMPA, medroxyprogesterone, because it is effective treatment for endo, especially when it comes to adenomyosis, when it comes to ovarian cysts. It's actually quite effective in shrinking the size of the cyst, in controlling the adenomyosis. But lately, they actually have, I think in earlier part of this year or end of last year, they actually started to have more papers on the long-term safety of medroxyprogesterone. Of course, we know that medroxyprogesterone, the limitation of usage is 2 years, because more than 2 years, there's a risk of osteoporosis. So even before, for medroxyprogesterone, we usually only use for 2 years. But since last year, there's actually a lot more data coming up with the concerns of cancer relationship, because medroxy does increase slightly the risk of certain types of brain tumor, and may also affect the offspring as well. So that's why since last year, if you look at the worldwide data, in some countries, they started to withdraw. Yeah.
Once you have registered for the Zoom,
oh, sorry.
Logged in when
yes.
you have logged in,
sorry.
It means that your attendance.
Yeah, so actually starting from last year, like European Union has begun to withdraw medroxyprogesterone because of these new findings of long-term safety. So that's also why actually I also have stopped using medroxy since last year. Yeah.
Oh, I know. Thank you, Dr. Mali. Okay. Next question, number 9. How can we push for the recognition that endometriosis is a pertinent health issue for women of all ages and not just categorized as chronic pain?
Yes, so the recognition is important. Recognition comes in levels, as in recognition in public, recognition among doctors, recognition in the government levels as well. So it's a very, I would say it is a very challenging task, because in different levels, there will be many obstacles for this condition. I mean, my feelings is that for me, for the past 10 years, I'm sure Mira also experiences this. Initially, when we started to do awareness campaign, actually not many people know about this condition, because people always thought that this is just normal period pain, right? But with more education going on, I mean, worldwide, there's a lot of awareness campaign going on. We are also giving talks to a lot of people trying to recognize the issue. And also there's a lot of patient advocates as well, right? So like Mira is a very good example. She has been doing a fantastic job trying to raise this awareness, trying to advocate for this disease. So I think everyone can play a role in this part to be advocates for this condition, for the society to know that it is not normal to have period pain. When the pain becomes severe, affecting your quality of life, it is not normal, right? And with more people understanding this condition from public point of view, I'm sure from medical field or in the work environment, people will slowly realize, oh, it's really not normal to have period pain. Even the doctors as well. So I do have a lot of family physicians now referring cases, because now they also started to recognize, oh, if the patient's coming quite frequently for MC once a month, it is not normal. We need to rule out these conditions of endometriosis first, right? So in the primary care settings, I do see an increasing recognition of endometriosis. Yeah. Government levels, I'm sure with all the work that I've done, I think Mira also working quite closely with minister level for them to recognize this condition. But I do think a ground up effort is very important for everybody to realize the impacts of this condition. Of course, in the medical field, patient outcome as well as research, it does play an important role in for people to realize the impacts of endometriosis on the healthcare system.
I agree. I feel that more often than not, patients feel that, we are just one voice. So they tend to shy away from advocating, feeling that their stories or narrative is not important. But then again, I feel it's important to let everyone know that I was just one voice as well. So if you feel that you are not making any difference by sharing your narrative, then let me tell you this, it is important. So there is no effort that is too little. So as long as we are doing it together, one voice become larger advocacy, and we can continue on in a larger scale. So please, even if you are just a one voice, continue advocating. Don't shy away from it. Keep reaching out to others, keep reaching out to your close ones, and keep advocating for awareness. Okay, moving on to the next question. Right. What does patient need to prepare before and after surgery to remove endometriosis? So for these questions, let me try to assist on this. Dr. Mali, you can have a sip of water first, have a breather first, okay? Okay.
Yes.
Okay, I have written actually an article based on my personal experience. In it, I shared what to expect before and after surgery, what I packed for my hospital stay, nutritional tips that work for me. Of course, you can, it's just a guideline of which you can try out. If it works for you as well, then it's good. And coping mechanism that helped me during recovery. So we encourage you to check it out for a first-hand perspective and practical guidance. So please scan the QR for the full article. More resources are available on our website. It's www.endosupport.sg. So please take a look at them. All right. Moving on. Question 11. Is there any relation between endometriosis and miscarriage?
Yes, good question. So we know that endometriosis is considered endo outside of the uterus, right? So it will affect, so first of all, it may affect the quality of the eggs. So quality of the eggs, if it is poor, it does translate to slightly higher risk of infertility as well as miscarriage. And we do also know another bigger impact on pregnancy is endometriosis. A lot of times it do coexist with adenomyosis. These two are sister conditions. So adenomyosis means endometriosis inside the uterus itself. So these adenomyosis do have much bigger impacts to pregnancy itself compared to endometriosis, because you can imagine when the uterus is being affected by adenomyosis, means that actually there's a lot of chronic inflammations, there's scarring in the muscle layer of the womb. So when the embryos is trying to grow into the womb, they need to be implanted inside the womb well in order to grow well. But adenomyosis affect pregnancy in the implantation stage. So whether it's through natural conception or whether through IVF, this is the part, unfortunately, adenomyosis is something that IVF cannot overpass. So if it affects the implantation of the embryos, it may not implant, means that cannot get pregnant. It may implant poorly, means that you get pregnant, but implantation is poor. So what does that mean? So if their implantation is poor, then there's a risk of miscarriage. There is also a risk of preterm labor, means that baby may deliver prematurely. And when the implantation is poor, the blood flow from the uterus to the baby may also be affected. Thus, there's a higher risk of getting IOGR, means that baby growth restriction during pregnancy. And also because the blood flow is being poor, there's a very high risk of mommy getting hypertension, because hypertension in pregnancy is called preeclampsia. Preeclampsia actually, one of the reasons is because of the blood flow from the uterus to the placenta is affected. So if this part is affected, then there's higher risk for mommy to develop preeclampsia during pregnancy as well. The other thing is that when implantation is affected, it may not implant into the normal position in the uterus. So sometimes we do realize that with adenomyosis, there's higher risk of mommy getting placenta previa, means that the placenta is implanted in a much lower position. So all these are linked to endometriosis and adenomyosis. That's why when we know that this lady is having adenomyosis and got pregnant, usually I do advise them to see an obstetrician who's experienced in dealing with high-risk pregnancy, because we know along the way, these are the issues that may pop up during the whole pregnancy. Hope this answers your question.
Yes, it does. I'm learning as well, for sure. So the next question will be question 12 and 13. And the key concerns is overlapping. So I will read through question 12, followed by question 13, and then I will try to sum it up in areas where we can simplify it together. Okay, question 12. Is there any medicine, supplements to help manage period cramps when painkillers don't really help? One doctor that I visited suggested evening primrose, but I don't think it helps improve my cramps much. How do we get a referral to your clinic for your scans? The ones I went to couldn't detect anything, and it's frustrating. If there's something, at least it can be taken out, but they detected nothing at all. Question 13. I'm aware of endometriosis, but gynecologists that I visited in government hospitals, etc., always dismiss my pain as normal, as no cysts were found in my scans. They asked me to continue taking painkillers for better quality of life, but painkillers don't help me. I'm always bedridden, at least for the first day of the period. Do you have any recommendations of scans out there that can detect this? What's the most common symptoms? We just talked about the scans just now and how important it is to get or to approach a correct specialist, right? So I think we answered a bit of that for these two questions, but let me just sum it up into 4 areas. I can see here that first area will be on how to manage period cramps when painkillers don't help. Secondly is why scans might not detect endometriosis. And third, persistent pain despite normal scans. And the last one will be how can they reach out to you for scans, and is a referral possible? Dr. Malu.
So when it comes to period cramps, or when we need to decide what is the reason for the period cramps, we need to know what is the pain generator, means what are the real conditions that cause period cramps. So period cramps, of course, does not equal endometriosis. There's many other conditions do contribute to chronic pelvic pain or period cramps too. So so the diagnosis is the key. We need to know what caused the pain. So whether it's endometriosis, whether it's pelvic congestion, which is another completely different condition that contributes to pelvic pain, whether it's irritable bowel syndrome, right? So, or whether it's myofascial, which is the pelvic floor muscle problems. And even when it comes to endometriosis, we also need to know where is endometriosis located. So I always emphasize the location of the endometriosis actually matters more compared to the size of the cyst. It's much more important because endometriosis, a different part of the body organ, do give you different kind of pain. And different types of endometriosis do require different types of treatment as well. So that's why it's always important to know whether it's because of endometriosis, and if it is because of endometriosis, what is the location of the endometriosis that cause pain. Then we will have a actually a very highly individualized treatment plan for each individual patient, depends on the location of the disease. So that's why endometriosis mapping scan is very important. Of course, I understand that the expertise in this area is still very few. I mean, worldwide it's the same problem. So when it comes to endometriosis mapping scan, you really need to find those who are trained into doing mapping scan, or else like what this patient experienced, the scan only found no cyst in the ovaries. Does that mean no endometriosis? No, because only 20% of the endometriosis do have cysts. The 80% of the time, the endometriosis are elsewhere. And those are the ones that really, really cause pain. So we cannot just rely on no cysts to diagnose and no endometriosis. This is wrong, right? So that's also why painkillers does not help. So having an exact diagnosis or mapping is very, very important. But of course, in some of the clinic, if we realize if some of the doctors may not be able to do a mapping scan, another equally good ways is to do MRI scan. So MRI scan can also help us to detect endometriosis. There's pros and cons for each approach, because you can imagine when we're actually doing endometriosis mapping scan, we can see the disease there. But because scan is dynamic, we actually can push the different parts of the organs to see whether there is any scarrings as well. So scarring means adhesion when two organs are stick together. It may not have endo, but adhesion, some of the times it will also cause pain. So that is the advantage of doing scan, because scan can also help us to see whether there is any adhesion between organs. When it comes to MRI, because MRI is static, so what can MRI detect is whether there's any nodular, whether there's any endo. But for adhesion, I realized that it may not be so good in detecting whether there's any organs being stick together. So that is the limitation of MRI scan. But there's also advantage for MRI scan is that because pelvic ultrasound scan, when we scan from below, we can only assess the pelvic area, but we'll not be able to see the upper abdomen, like appendix, like small bowels, or any of the rectum that is sigmoid colon, which is maybe 20 cm away from the anus. So that is, ultrasound scan is limited. So MRI, in a way, is better to see slightly higher disease at higher location. So if we do pelvic ultrasound scan, everything's clear, but still having a lot of pain, which cannot be explained, or have a lot of bowel symptoms, we might still need to do MRI to see whether there is any upper abdominal disease. But again, the other thing that we do need to watch out for is who reported the MRI scan. So this comes to the question of endometriosis specialists, because for us, usually we cannot only rely on the report that was given to us. Whether the radiologist can detect endometriosis MRI also depends on their training, right? So when we read like thousands of images, if I don't see, I won't report, understandably, right? So if a radiologist is not trained in reading endometriosis, they may not written on that report. So we cannot rely on that report either. So whenever my patient have an MRI scan, I need to go through the images myself to see whether there's endometriosis rather than relying on the report itself. So that's how we diagnose endometriosis, and that's how we know the exact location of endometriosis. For referral to my clinic, you can just Google my clinic website is available. You just drmaliclinic.com and then
Yeah, Dr. Bali.
oh yes, thank you, Mira. Yeah, so you can also email
Then
or website. This is the number that you can call for appointment. And then usually, we try to schedule appointment as early as possible because I understand that you're really in a lot of pain, and we try to arrange the appointment within 2 to 3 weeks time. My staff and me will try our best to accommodate the request as early as possible.
So for patients, probably if you're thinking this would be under private. So if you're thinking if that's like a referral from a polyclinic and whatnot, there isn't. So you have to straight away make an appointment through the details that I've provided displayed on screen right now. The email address is there, the website, the contact number is the clinic's contact number, as well as the WhatsApp is also the clinic's WhatsApp number. So please book an appointment with her should you feel that you need further explanation, consultation from Dr. Mali herself. All right. So let's move on to question 14. What is the cost of initial workup, including scanning blood work in private practice? A rough figure, Dr. Mali.
I think each clinic varies a little bit. Yeah, so I cannot say for other clinics. Also depends on what test is usually done, right? So I think for ultrasound scan, from what I understand, because ultrasound scan can have a routine, just gynae scan focusing on uterus and ovaries, can also be a detailed scan that focusing on all the endomapping, can also have a vascular scan to rule out pelvic congestion. So all these prices do differ, depends on what kind of scan is done. It's usually in a range of hundreds to 300s between that. MRI usually is slightly more expensive. It is about 1,500 to 2,000 in private practice. I think in public hospital might be slightly cheaper. From what I remember, is about 1,300 to 1,500. So this is the initial workup that's usually done for endometriosis diagnosis. Blood test usually is not necessary. Blood test is not necessary to diagnose endometriosis, but for some patients, for example, young patients who are planning for fertility, we might need to do ovarian reserve test. Ovarian reserve test is through a blood test called anti-Mullerian hormone. How much is it? I think maybe less than 100, less than 50. Or for those patients who we may suspect there might be a concern for malignancy, then because based on the scan, sometimes we do see suspicious areas, right? So if we do need to know a little bit more, we may need to send off the tumor markers. Then there will be the blood test usually is a few $100 for tumor markers. But also that it's not necessary for every single case. It really depends on that individual patient, what is required for that patient.
Okay, next question, 15 and 16. So for this question, let's have Dr. Mali take a breather for a while. I will assist you with this question. So question 15, since there's an overlap between endometriosis and IBS, should females with endometriosis go on a low FODMAP diet, or what's the proper management? And this person actually thanked Dr. Mali for answering. I will answer for you, okay? Not to worry. And question 16, is there a relationship between the food we consume and the inflammation of endometriosis? Okay, so the answer for these two questions is yes. There is a strong relationship between diet and inflammation in endometriosis. So while diet alone cannot treat endometriosis, but certain food may help reduce inflammation, regulate hormones, and manage symptoms, while others can worsen pain and inflammation. And this is enigmatic, so it depends on individuals. So for myself, I do have a food log to ensure that I know what I'm eating for the day and observe how I feel. So for example, if I start feeling bloated, uneasy, so at least I can check and identify the cause of what's causing me feeling that way, you see? So I encourage everyone to go ahead and have a food log if you can. It's very easy. There's a lot of app nowadays. So the app that I'm using is MyFitnessPal. So you can download it for free. and start tracking your food log on a daily basis. So it really helps. For me, it helps. Okay, and then the next one here, it is the topic was extensively covered in one of our quarterly Zoom sessions. And for this, it's entitled Endometriosis, Exercise and Nutrition. And in this particular session, we actually discuss about FODMAP. So what it is, the difference between low and high FODMAP food, and its potential impact on endometriosis symptoms. We also have a wealth of resources available for you covering topics like nutrition, training, pelvic physiotherapy, TCM, and more. So you can access through our YouTube live stream recordings or videos at your convenience. So to watch this particular one, you can just scan the QR code. And if you want to go through the rest of the videos or live streams, the previous live streams that we had, just go to our YouTube channel, E for Endometriosis. Okay. All right. Now moving on to question 17. Can blood tests help indicate the presence of endometriosis? If so, what specific blood markers or tests should be considered? I think you answered this just now, right?
There's no blood test can indicate presence of endometriosis. I mean, I do understand a lot of clinic, they use the marker of CA125 to see whether there is any presence of endometriosis. But the answer is, it's not a very sensitive marker for endometriosis. It is actually, a lot of condition can cause endometriosis, can cause CA125 to be high. For example, if you do the blood test during the time of your having period, then they will be slightly higher. Fibroid can increase it. Pregnancy can increase this level. Of course, endometriosis sometimes can increase this level, or cancer can increase this level. So it's not a very reliable marker to diagnose endometriosis. So I know like there are some lab is trying to develop some biomarkers to diagnose endometriosis, but so far it is not validated yet. Again, when it comes to diagnose, it's not only, okay, we know that you have endometriosis, but what is more importantly, as I said, is to know the exact location of endometriosis. So far, none of the blood tests has been able to tell us the location of endometriosis. So no, there's no blood test that can help with diagnosis. So still, we need to rely on mapping scan or MRI to diagnose.
Right. Next question, question 18. Would you have a basic guidelines for pain management for different types of pain, different pain pathways, and say for inflammatory pain in dysmenorrhea, pain arising from adhesion site, etc.? I can't possibly take Tramadol daily.
So, and said actually pain, we will have different pain generators. So it's always important to know what is the pain generators, right? So of course, if there is a neuropathic pain, neurogenic pain, if the pain is arising from the nerve kind of pain, usually we do give carbapenem or pregabalin to help with nerve-related pain. But if the pain is coming from endo, because of the inflammation of endo, the adhesion arising from the endo, of course, if we're talking about a painkiller only or medicine only, so the source of the pain is because of the organ itself that is affected by endometriosis, in which we do need to take hormonal medication rather than just painkillers. If the pain is arising from adhesion, we also need to know where this adhesion coming from. Is it because adhesion to bowel that caused the kind of colicky pain, or is it because of the adhesion is affecting nerve, causing neurogenic pain? In which case, the painkiller that we use might differ a little bit, depends on where is the adhesion coming from. But when it comes to adhesion, of course, a lot of times medication may not be that strong enough to help. So for very severe adhesion-related pain, which failed medical treatment, we might need to consider either physiotherapy or surgical removal to release all this scarring. Yeah.
Right.
So it's important to know, where is the pain generator.
Yeah, I feel that a holistic approach is also important because although you are taking medicine, for example, even painkillers on standby on days that, it's very, very excruciating. But on a daily basis, on a consistent basis, I also believe the importance of, nutrition as well as physiotherapy, a certain kind of exercises that suits your situation and to manage the pain itself. So it's not 100% just reliant on medication itself. It's also an approach where we have to deal with it as a whole. So that is, I believe, important as well. Okay, I'm so sorry about my brain fog because question 19 is actually the same thing as question 18. So we'll proceed to question 20, right? So moving on to question 20 now. Is it normal to have prolonged pinkish discharge post-menses when you have endometriosis? Example, more than 10 days.
Okay, prolonged discharge, any kind of bleeding, including any kind of, sorry, there's some noise outside. I think they're renovating. Okay, so any kind of spotting or bleeding, which is more than 10 days, is abnormal. We do need to know where it comes from. So it's always important to do a very systematic examinations to check whether the bleeding coming from vagina, whether the bleeding coming from cervix. So, and also we need to do a scan to see whether the bleeding is coming from the endometrial cavity itself. For example, if there's a cervical polyps or abnormal pap smear or cervical mass, it will tend to cause bleeding. Or if there is a polyps inside the cavity of the womb, it may cause bleeding as well. Adenomyosis will cause bleeding as well. So basically, to answer this question, it is not normal to have prolonged spotting or pinkish discharge for more than 10 days. It's always important to have a thorough check to make sure, to check where is the bleeding come from, whether there is any further investigation that is required.
Right. So I do hope that the person who asked this question get herself checked right away. Okay. Question 21. Can tranexamic acid, is it correct? And painkillers, yeah. And painkillers be used to manage endometriosis and adenomyosis long term.
Yeah, so tranexamic is a medicine that helps with reducing the bleeding. Yeah, again, so these two are not considered long-term treatments. Sorry about the noise. So they are symptomatic treatment. So for those people who really have a lot of pain, need some painkillers to treat the pain, yes, we give painkiller. Or for those who have very heavy bleeding, we give this medicine, tranexamic, to reduce the flow. But these two, they just treat the symptoms. They don't treat the disease itself, right? So that's why we do have a lot of patients who previously on many kind of painkillers. But the problem is that if we don't treat the disease, the endometriosis and adenomyosis will progress. And gradually, people will realize that the dose of painkillers, the kind of painkillers they're taking is getting stronger and stronger and become less and less effective. And also the bleeding might get heavier even despite of the tranexamic. So these two, to be simply put, is not a medical treatment for endometriosis. It's more of a symptomatic treatment. So we still need to use hormonal or surgical to manage endometriosis or adenomyosis in the long term.
That's a clear answer. It's a no, okay? So please get yourself treated properly. Okay, question 20 to the next one. Are there any alternatives to Visan since endometriosis is an inflammatory condition? Are there new drug candidates in development currently?
Yes, there are quite many alternatives to Visan. So as mentioned just now, Visan is progesterone treatment, right? So progesterone treatment can have the form of oral tablets, various forms like Visan is one of them. It can also come in the forms of implant, like Mirena implant is a device that we put inside the womb. And this device do have progesterone on this device, which will be releasing to the womb on a daily basis, which can last 5 years' time. So these we can also consider oral contraceptive pills, which is a combined hormone pills, including progesterone and estrogen. So which medicine suits this patient better? Again, it depends on the severity of the disease, location of the disease. For example, when it comes to the Mirena, which is the implant, usually it works better for adenomyosis rather than for pelvic endometriosis, right? So or when we're choosing in between progesterone versus combined like oral contraceptive pills, there's also a concern because for very young girls, we try not to. Young girls means that those less than 21 before they reach the bone density. Then we try to give a little more estrogen in order to protect the bones. So this is the young girls where we might be starting with combined hormone pills rather than giving progesterone only pills. Are there any new drug candidates? Yes. Actually, it's also not that new. So in European or US, they have medications. It's called generic antagonist. It is in oral tablets form. So again, this works theoretically. It's also similar as Lupron and all the injections to give you a short period of menopause. So far, this medicine is not available in Singapore, and we do have a lot of concern over this medication because, again, it does comes with a lot of long-term side effects as well. So that's one of the reasons why we're not getting this medicine to Singapore yet, and also price concern is another big problem. Yeah.
All right.
I'm really sorry for the knocking outside. I don't know what they're doing outside my clinic.
They're joining our discussion maybe.
Yes.
But yeah, we can hear you loud and clear here, so not good. Thank you. Okay, question 23. Okay, so this one I will help answer for this time round. Could exercise and manual therapy help with adhesions due to endometriosis, at least to keep the tattered areas fairly mobile? The answer is yes. Exercise and manual therapy can help manage adhesions caused by endometriosis, particularly in maintaining mobility and reducing discomfort. So it's pretty much to just manage the symptoms and not treat. Again, the answer here is not treat the condition. While they may not completely break down adhesions, they can prevent them from worsening, can improve flexibility, and therefore reduce secondary pain caused by restricted movement. Okay, so consulting with a specialized pelvic health physiotherapist can provide personalized strategies to manage adhesions and maintain mobility effectively. They can tailor exercise programs and manual therapy techniques to your specific needs, ensuring safe and effective management of endometriosis-related adhesions. And again, I would say this, we have valuable resources available on our YouTube live streams like this one here, and videos covering topics such as this one here, pelvic physiotherapy, nutrition, and exercise. So you can scan the QR code to read the full article or the full video, to watch the full video in fact. And the rest of the videos is available on our YouTube channel, E for Endometriosis. All right, moving on to question 24. What are endometriotic plaques, and is there a criterion for excision?
I presume this endometrial plaque are what we call deep endometriosis. So it's different from a cyst. It's usually a solid nodule that is started to invade into the surrounding organs. So criteria for excision, usually for this one, if we need to do surgery, for all types of endometriosis, we do need to surgery. We need to aim for complete excision rather than ablation itself. And even do excision, we'll have to make sure the whole disease is removed properly. Yeah, so I presume this plaques is what we call a deep endometriosis.
Right, and in fact, when I discuss or give explanation in a layman terms, right, between excision and ablation, I use this for women. We have this waxing as versus what do you call this? Shaving. So
That's true. That's true.
right?
That's a good way. That's a good way.
So I would say that excision is removing totally, like you're doing your waxing. So whereas ablation is just like shaving, you are not totally removing it to the core. Okay?
Yeah, exactly.
So the difference between excision and ablation, if we could put it in layman term, right?
Yeah. Oh, that's a very good way, Mira.
All right. Okay. Next question. Question 25. Is your advice for teenagers typically the same as for adults? As in, is it better to get lesions excised before they become a bigger problem or leave them? I've heard time and time again that it usually comes back.
Yeah, so very good question. I think whether it's for teenagers or adults, the aim of endometriosis surgery is always to do one good surgery at the right time, right? So timing of the surgery is very important. So of course, with teenagers, we have to be very careful because I do read like many tragedy stories where young girls going for surgery and then a few years later comes back, go for another surgery, then they might have like 4 or 5 surgery in their whole life just to battling this disease. And this is what we're trying to avoid because we know that multiple surgeries, it does create a lot of scarring problems as well. And then there's also a chance of recurrence. So finding the best time to do the surgery is important. So how to find the best time to do the surgery? It comes to a few important factors. What is the age of this girl? What are the symptoms that she's experiencing? What are the locations? So again, location matters more rather than the size, right? So if on the scan, we realize it's just a cyst, there's minimal symptoms, there's no deep infiltrating endometriosis, not invading organs, not causing organ damage. This is a time, yes, we can try to manage conservatively first because we know that endometriotic cyst tends to respond to hormonal treatment better. With enough duration of hormonal treatment, cysts will get smaller. In this way, we are trying to delay or avoid the surgery until they are ready to conceive. But of course, if on the scan, we see there's a lot of deep endometriosis, like I said, bowel or ureter, or those are the ones who typically does not respond to hormonal treatment, we have to do surgery. Or if on the scan we realize there are deep endo, but there is still not causing organ damage yet, still a bit further away from bowel, not invading to the bowel, or not invading to the ureter. Then this is the type where we can also try with hormonal treatment or physiotherapies to manage the pain. But this too requires a very close monitoring, make sure they are not invading to the other organs. So for those who really have no choice, realize actually even as physio or even hormonal treatment, pain is still persists, then we do surgery. And then do surgery at the right time and do a good surgery. Good surgery means, as what we emphasized before, good surgery means a proper excision surgery is the key. Because if it is a complete excision, there's actually the chance of recurrence is low. And again, follow-up is also important. Follow-up means that whether hormonal treatment or physiotherapy, these two are very important two arms of prevention of the pain from coming back. So hormonal treatment would reduce the risk of recurrence from 30% to less than 5%. But again, physio helps with prevention of the scarring because you can imagine that at the time of surgery, we do remove the old scar, right? But new scar will come back because this is how our body heals. Our body heals by forming a scar. But majority of the time, if the scar is loose scarring, not fibrotic, not very far away from the organs, we won't feel anything. But if the scar becomes very, very tight, very, very hard, the kind of scarring, or very near to organs like bowel, nerves, etc., these are the type of scarring that cause pain. So how to reduce this kind of scarring? So again, surgical technique is very, very important. So we have to be very meticulous at the time of the surgery. One is to make sure the disease are removed properly. But again, we have to avoid so technical wise, we have to avoid a lot of burning to the tissue itself. We have to make sure there's no bleeding at the time of disease. So surgical technique is important. And at the time of surgery, we do need to put anti-adhesion barrier. So this is kind of barrier that helps to prevent organs from stuck together. But again, this barrier only stays in the body for about a month. After that, we do emphasize the importance of pelvic physiotherapy. So by doing manual therapy, it does massage those areas that we did operation on so that it will prevent the organ from stick back together and also prevent the scarring from becoming too fibrotic. So with this approach, so find a good timing for good surgery, and then after the surgery, hormonal plus physiotherapy. Actually, with this approach, our recurrence rate is very low, and especially for those needing repeated surgeries, it actually is very, very low. That's why first surgery is always very important to get a good surgery at the right time. And then post-op is also equally important.
Right, Dr. Mali. Kind of like lagging over there. Okay, now you're fine.
Okay.
You are lagging at the end, but
Oh, I see.
yeah, it's what she was saying is that it's very important to get the very first surgery right at the right time, complete surgery, because this would lower down the risk of recurrence, and in fact, hopefully enables you to live a better management of endometriosis in the end. But it's not just about surgery itself, but it's also ensuring that you also continue following up, taking the medication, as well as following up with your physiotherapy to ensure that you are able to manage the symptoms better. Because as Dr. Mali mentioned earlier, when it comes to surgery, there will be a new scar developed because it is part and process of healing. So it's therefore important to follow up with medical consultations after that, as well as physiotherapy. Okay? Okay, next question. Question 26. Okay. Oh, was it the same thing? Was it the
Yeah.
same thing?
Okay.
Oh,
It's 25.
it's the same thing. My bad.
826 is.
Yeah, so let's move on to question 27. Given the advancement in excision surgery, why is ablation still commonly performed despite its lower success rate? Why is shaving still performed, Dr. Mali?
Okay, so generally ablation is not advised for endometriosis surgery. Yeah. Yeah. It's not advised though. So before going for surgery, it's important to check with the doctors that they do a proper excision, not ablation.
But is there like a usual case whereby they say, I think it's more about us understanding and realizing the differences, because they wouldn't say that there is such a method as excision ablation. They will just mask it in this different jargon. So it's very important for us to take note of the differences ourselves. That's the reason why I feel that awareness is important. Get yourself educated on this is very important as well. So and ask question, don't be a blind follower. I keep on saying this to patients as well as during advocacy as well. Learn and continue asking question. Why are you giving me ablation? I heard that there is excision. Why are you not giving me excision? Ask question like this, okay? Don't be afraid to ask questions, right, Dr. Mali?
So it's good that we educate ourselves so that we know what kind of question to ask when it comes to the discussion of surgeries. Yeah.
All right. Now there's a sharing. So this is the end. Okay, so before we close, I would like to share one final reflection from someone within our community. This is a deeply personal journey that many can relate to, and it highlights why conversation like this, like what we're having right now, are so important. So this anonymous sharer writes, I had a similar experience as a 36-year-old patient, one open surgery to remove 2 cysts. Subsequently, I found out I have low AMH, went through IVF and was unsuccessful. An egg donor was the suggested option to have my own baby. Unfortunately, I found out about this support group late. Oh, that's very sad. Now, this experience is one of many, and it is a reminder of why advocacy, awareness, and access to support are critical. No one should feel like they are navigating this alone, and no one should find out about the resources that could help them only when it feels too late. So this is why We do what we do to ensure that information, community, and support are available at every step of the journey. Dr. Mali, as we close this session, I would like to invite you to share any final thoughts with us.
Yeah, I think endometriosis awareness is very important because this is a disease that is so common, affecting 10 to 15% of the patient in reproductive age, and it
Sorry, Dr. Mali, you are lagging again. We lost you there.
team do realize that a lot of endo experts do realize that the best tool is for patient education, self-awareness, so that you know what kind of treatment you need and what kind of, so for example, if you go to see a doctor was given wrong advice, at least you will be able to recognize it and then go seek second or third opinion to find the right doctor for treatment. So although there's still a lot of things that we need to do to improve awareness among medical professionals, I think by self-educate is really so far the most powerful tool for y'all to get answer yourself and get the correct treatment.
Thank you so much, Dr. Mali. And that brings us to the end of today's Q&A session. We want to extend a heartfelt thank you to Dr. Mali for her time, expertise, and dedication to answering all these questions with such care and depth. And of course, thank you to every single one of you who submitted questions and helped make this initiative a success. We know that endometriosis is complex. We know that it's often misunderstood, but we also know you are not alone in this. So the more we ask, the more we learn, and the more we advocate, the closer we get to breaking the silence and ensuring that no one has to suffer in the shadows. So if today's session has been helpful to you, please continue sharing this with others who might need it. The full session will be available on our YouTube channel, so you can revisit it anytime for free. Share it, okay? Share it around. Okay, and then we have this one here. Before we go, I would like to also invite you to our next session, which is endometriosis in Asia. When will the silencing end? So this is for the first time ever, patient advocates, not just from Singapore, but also Malaysia and Indonesia are coming together in solidarity for a groundbreaking discussion. So this is a moment in history where voices across our region are uniting to expose the reality of endometriosis and discuss its broader impact on mental and physical health. The silence ends with us. So please join us. Find all the details and register at e4endometriosis.eventbrite.com. Once again, thank you for being here. Keep learning and keep advocating. Your voice matters, your experiences matter, and together we are changing the future of endometriosis care. Take care, and we'll see you again soon.
Thank you.